Welcome to How I Do It, a short video tutorial featuring leaders in the endoscopic spine surgery community discussing interesting topics that affect our practice. I'm neurosurgeon Dr. Paul Houle, and today we'll be discussing how to treat complications of ALIF and OLIF with Dr. Albert Telfeian. So let's get to it.
All right. We're just going to talk today about endoscopic spine surgery solutions for lateral fusion complications. This is me doing endoscopic spine surgery, and about 99% of what I do is with the patient awake in the prone position. And you can see I'm using an endoscope down an endoscopic tubular retractor. I'll use this picture to illustrate to patients that the size of this tube is exactly the same as a number 2 pencil. It's 7 millimeters, and you can see I'm wearing loops here, and that's just for eye protection so that I can see the needle like close the skin. This is all visualized using a high definition computer monitoring. The first complication of lateral fusion complications I'll discuss is herniated discs. So this is a young female who had a L4-5 lateral fusion and an L5S1 ALIF, and she had right L4-5 radicular symptoms after her fusion surgery. An MRI showed a rather large foraminal disc herniation here, and we performed an endoscopic decompression. Now you can see this is an AP fluoroscopic image and then a lateral fluoroscopic image showing the tubular retractor. On the lateral image, you can see it's just on the top of the disc space here at L4-5, but on the AP image, you can see it's almost to the midline. So this is to illustrate that this is actually foraminal surgery. This is not intradiscal surgery. Here, the tubular retractor is on the disc pathology. And then that's exactly right. That's a very good point to make that illustrates that we really are doing foraminal surgery. And then when I introduce the high definition endoscope, you get a 360-degree porthole view of the foramen. So down here at 6 o'clock is the end plate of L5. And then this is the right L4-5 foramen. So at 9 o'clock here, we have the pedicle of L5. We have the traversing L5 nerve root going here horizontally. And you can see I'm introducing an endoscopic grasper to remove the disc herniation. When we talk about in our advanced user group meetings that we use the irrigation as another instrument. So as I introduce the endoscopic grasper here, it's increasing the endoscopic fluid's pressure and deflecting that nerve root away. This acts as really a nerve root retractor so that I can easily and safely grab pieces of the disc. Now, you understand that the patient is awake here, so it's very safe. I know if I'm touching the nerve root, and I'm able to see as I remove more and more disc, the nerve root will pulse more freely.
Sometimes the converse can be true. So when you're going after a large loose fragment, sometimes the water pressure when you put the instrument in can actually push the fragment away from you and you have a difficult time grasping it. So sometimes I'll actually turn down the water pressure to allow me to grab a loose fragment.
I think that's a great point. That's really a good point for advanced users. I learned that lesson the hard way. I broke a K-wire off in a patient, and then I used the endoscope to retrieve it. And my first attempt, I didn't turn the irrigation off, and it pushed the K-wire away from me. And that's how I learned to turn the irrigation off so that I can get pathology like that. So this is just a good view. Now you can start to see some space underneath that L5 nerve root as we're decompressing it. The end plate of L5 is here. The pedicle, it's rather shaded here, but this is the pedicle of L5 going vertically here as it wraps to what is the residual portion of the superior articulating process. So our crown reamers have shaved off a portion of this superior articulating process where it meets the pedicle in order to give us this beautiful foraminal window to the traversing L5 nerve root. The second case I'm showing is also a right L4-5 disc herniation after a lateral fusion, but this is in a patient that's 83 years old. He has a large foraminal disc herniation. And I show this one because in this case, I got a large spinal fluid leak. You see the sequential dilator docked on the superior end plate of L5, and then I'm just approaching the medial wall of the pedicle here. So when I introduced my last reamer to open up the foramen, I got high pressure spinal fluid out. So I didn't stop the surgery here. I introduced the tubular retractor here over the disc, turned the bevel upside down and the scope upside down as I removed the disc herniation, because when I looked up, I could see the cauda equina. Now, I was able to complete the surgery successfully. The patient went home the same day. I recommended about 2 days of bed rest, and his symptoms were resolved. I did an MRI 3 months after his surgery, and you can see I used this channel here through the right L4-5 foramen and how I violated the dura here. Now, this sealed up on its own. Patient didn't have any headaches or any residual symptoms. And I think the point to make here is that I always caution patients with complex pathologies, such as those who've had previous laminectomies or fusions, that they have a higher risk of spinal fluid leak. But I would not recommend in a case like this that converting to open to try to repair this. I think the chances of a spinal fluid leak happening after an incidental durotomy is very low. So I think the safest thing to do is complete your surgery safely, and then just, I've used cases where I put in a piece of Duraform collagen matrix, fibrin glue, or nothing at all, and it usually seals on its own.
I think it's really important to note that CSF leaks, dural tears, are a completely different animal in endoscopic spine surgery. Typically, they happen on the ventral surface rather than the dorsal surface. This is sort of ventrolateral, but the point being is there's not a whole lot of dead space for a pseudomeningocele to form, and it's just a very different animal than an open surgery.
I think that's an excellent point. It would be more like comparing the durotomy we have with endoscopic spine surgery to the durotomy you get with a spinal tap. It's very rare to have a spinal fluid leak after violating the dura with a needle. The second case I'll present is contralateral end plate fracture. This is the second pathology we're going to discuss. And I published this technique with Dr. Wagner, Dr. Chuck, and Dr. Ibramberg in World Neurosurgery. And here's a case where a patient had an L3-4 lateral fusion and then fractured a contralateral piece of the end plate. You can see on the sagittal reconstruction this large piece of foraminal bone in the foramen at L3-4. And this is the pre-op, and on the post-op, it's been removed. On the axial image, you can see the fragment here, but on the post-op, it's been removed. The tubular retractor, again, is inside the foramen. It's not inside the disc. And that's where a grasper, an endoscopic grasper, can access the pathology. The next slide are endoscopic camera views of the operation. Now here, this is that porthole endoscopic view where we have the pedicle of L4 here and the SAP of L4. Dr. Wagner is using a shrill drill to drill down some of this superior articulating process to create a nice foraminotomy. And then he'll turn the beveled cannula and the scope upside down so we can visualize the L3 nerve, which now you can see is compressed by that bone fragment. He's able to easily remove that fragment in one piece with an endoscopic grasper, then revealing the titanium lateral fusion implant and the well-decompressed L3 nerve root. I think it's an excellent description of how well these pathologies can be visualized with our high-definition endoscopes.
And it's a great illustration of what you can actually visualize with the endoscope, because there you are looking right at the cage itself. And in fact, in one of my cases, I was actually able to read the serial numbers off of the cage, which I thought was quite incredible.
Yeah, and that's my experience exactly. The high definition cameras are 1 to 2 millimeters from the pathology, and what you see is beautiful. The next pathology I'll illustrate is a less common one, but foraminal heterotopic bone after lateral and oblique fusion. So this patient had an L4-5 OLIF, and the surgeon used BMP with the allograft. And you can see the left L4-5 foramen is widely open, but the right L4-5 foramen is almost completely occluded with heterotopic bone. And when you look at the coronal reconstruction, you can see a large extruded fragment of heterotopic bone here compressing the exiting nerve root. And here on the axial image, you can see the foramen almost completely occluded by this heterotopic bone. This is a complicated case, and I used frameless stereotactic navigation for the case. And I fixed the navigation star on the patient just using an IA band. For targeting, I'm using a navigated jam sheety needle, which I'll dock just on the end plate of L5, just medial to the pedicle of L5. And endoscopic camera views, you can see the shrill drill used to drill out this heterotopic bone, a portion of the peak cage as well, until I can see just the threads of the L5 pedicle screw. I'll remove some soft tissue disc herniation, and then I can see the well decompressed L4 nerve root. One of the advantages of using navigation for this case was that I have intraoperative CT. So you can see on the pre-op, we see the cage and the heterotopic bone, but on the intraoperative, postoperative CT, we can see how I've reestablished the foramen completely open, and the patient had immediate relief from his symptoms. And the last pathology I'll discuss is actually direct compression from the lateral fusion cage. So this patient had an L4-5 lateral fusion. The surgeon approached from the right, but you notice the cage was pushed in a little too far. I think this happens to us a lot of times without any patient complaints, but in this case, it was enough to compress the patient's exiting L4 nerve root. And you can see this, it's just probably this little edge of the cage here. So I'm able to introduce the endoscopic tubular retractor here. You can see how far I am past the medial wall of the pedicle, and then back it up, drilling off as much of this case as possible. And again, the patient had immediate improvement. So to summarize, we've covered herniated discs, fractured bone. We've covered peak implants compressing the exiting nerve. And we've also discussed heterotopic bone formation after lateral fusions. So these are all complex complications after minimally invasive complex spine surgery that can be remedied with endoscopic spine surgery.
I couldn't agree more. And I think another important point is if you look at frame D, the tubular retractor, with the way the bevel is, it's a tool that you can use to protect the dura or the traversing root or the exiting root if you need to while you're using that high-speed drill. So your neural structures are completely protected while you do your work. And I think that's a point that isn't truly understood by a lot of people who don't do endoscopic spine surgery.
I couldn't agree more. I think understanding that tubular retractor really acts to retract the dura so we can safely access pathology is really one of the keys to the procedure.
I'm going to bring it back to our thing here. So that was an absolutely wonderful presentation, and thank you so much for sharing with us. You also have a fellowship program at Brown. Is that correct?
That's correct. We take about 3 fellows a year in our complex spine neurosurgery fellowship. It's a very robust fellowship. It includes spine oncology, deformity, trauma, congenital spine, and minimally invasive endoscopic spine surgery. I'm very proud that all of our fellowship graduates go on to practice endoscopic spine surgery in their practices.
So I just wanted to throw that out there in case there are some residents that are watching, and hopefully if they have an interest in endoscopic spine surgery and looking to do a fellowship, I would suggest seeking out Dr. Telfeian because it's certainly you'll learn a tremendous amount. So I'd like to thank you very much, Albert, for sharing all this with all of us, and just keep on innovating and keep doing wonderful work. So I'm going to do, this is the part where I do my shameless plug.